I'm humbled, and Dr. Loafman are humbled by you coming tonight to hear what we have to say about joint replacement. I hope it's informative for you. Right off the bat, we're going to present you with a lot of information, which I think hopefully you'll find very interesting. And but we're going to leave tons of time for questions, and we're not leaving until we've answered all your questions. So this will be a very interactive type of presentation, hopefully, that you'll find. I'm Ken Edwards. This is my 25th year in St. Joe practicing, and it's wonderful. I started my career, I did my residency in the Navy at the Bethesda Naval Hospital in Washington, D.C., and grew up in New York, and my last duty station was Great Lakes, which is north of Chicago. And when you're from New York, one thing you learn about Chicago is New York without the hassle. And so we love New York, and so we put a net around the Chicago area and stumbled on St. Joe, and it's funny what a blessing that's been for us. So I'm going to start our presentation today with just to talk about arthritis in general and some of the conservative treatments for arthritis. Whenever we do joint replacement on patients, we always start with conservative measures first, and we want to talk about what's fact, what's fiction, and I hope we can spend a good deal of time today talking about a lot of the, I think, inappropriate marketing that goes on both with non-operative and operative treatments for arthritis. I think it's very confusing, in fact, and we'll go from there. So let's begin. So we're also here to brag a little bit. And you know, in my 25 years at Lakeland, I don't think we've done enough of that. And I don't think we're appreciative enough of what really a wonderful health system you have in the community. As you saw the picture of me before, I had a lot less hair when this picture was taken, and as most of you know, I had a little adventure with cancer last year, and I can tell you that I'm the product of phenomenal care that I received at this institution. But I can also tell you that objectively, we do extremely well, not just compared to our local peer group, South Bend, Kalamazoo, Grand Rapids, but we do extremely well nationally when it comes to orthopedic results and outcomes. And I hope we can reflect on that a little bit later. We're in the middle of a very exciting time at Lakeland. As you can see from this gigantic construction that we're doing out here, the end result of that is going to be a completely new surgical pavilion. Brand new operating rooms, brand new recovery rooms, and I think a really exciting investment in the community for all of us, as we go forward. And in our practice, we are also expanding a lot of our services to Niles. And so we're really trying to put a very comprehensive product together for you of high quality. But whenever you give talks, you have to give disclosures, and I think that's appropriate. I'm the medical director of surgical services, so I'm sort of appropriately proud of surgery here. And I'm on several board committees, but I have no financial relationships that I think might unduly influence my presentation tonight, and I think that's important that we know that. So today we're going to talk about a lot of things. We're going to talk about, what is arthritis? I think a lot of people don't even know what arthritis is. What's a joint replacement? Whenever I talk to patients, particularly about knee replacements, I think there are a lot of misconceptions about that. What technological things are we introducing in our community that are giving you the best opportunity for an excellent outcome? We want to talk about that quite a bit. We're going to talk about things that we're doing very specifically for individual patients. Nick's going to talk about anterior hip, which is a very exciting approach that we take with hip replacements in certain patients. I want to reflect a little bit about what the future holds, where I sort of see things going. I think it's going to be sort of disruptive for us. I'm 60 years old, and I'm a baby boomer, and I think it's going to be sort of challenging for us maybe in the future. And as I said, we're going to spend a lot of time talking about questions. But arthritis is a huge problem in America. And, you know, if we look, we can estimate about 50 million Americans have some form of arthritis. So that makes it a very major public health problem. And, you know, when we look at the change in numbers, if we look at 1995, 2 years after I started practice, I think 1 year before Dr. Loafman was born, you know, you can see the number of patients in the United States with arthritis. And then, you know, just a couple of years from now, you can see what projections are for that. So let's start with some basics. You know, what is a knee? What is a hip? You know, when we talk about a knee, just think of a knee as 3 cartilage-covered bony surfaces. So we have a kneecap, which we call the patella. We have the femur, which is the end of the thigh bone, and we have the tibia, which is the top of the shin bone. And you've got cartilage on those surfaces, and cartilage allows bones to glide on one another. And arthritis has an extremely simple definition. Arthritis is the loss of cartilage over bone, so bone rubs on bone. Okay, so very, very simple. So when we look at the hip is a ball that fits in a socket. The ball has cartilage on it, the socket has cartilage in it. And again, when we talk about arthritis, it's a loss of that cartilage over bone. So here's a great example of what happens as we develop arthritis. So the x-ray on the left is a normal knee. And when we look at cartilage on an x-ray, space equals cartilage. So if you have space between the bones, that means you have cartilage. Now if we look at the slide on the right, you can see that there is bone-on-bone contact, and that's a loss of cartilage. So that's the difference between normal and arthritic when we look at that. Now when we look at a hip, same thing. If you look at the slide on the left, you can see a nice round ball, and there's good space between the ball and the socket. If we look at the x-ray on the right, we can see that there's a significant reduction in the distance between the ball, and that is what arthritis looks like. So when we start talking about what are the indications to treat knee arthritis and hip arthritis, that's what we're talking about. And when we talk about arthroplasty, which is joint replacement, fancy word for joint replacement, you know, the numbers are staggering. Actually, this is a slide from 2010, but right now in the United States, over 750,000 total knees are done, about 400,000 total hips, about 70,000 total shoulders, and a lot of revision surgery is being done. Revision surgery means that a component either maybe gets infected and it has to be redone, or a component wears out and it has to be replaced, and we will talk about that a bit. And here's a very important statistic for all of us to think about. Total hip and total knee replacement comprise the largest procedural expense in the Medicare budget. So more than open heart surgery, more than cardiac stents, more than any of the surgeries you can think of. And that means that is creating an environment that is going to require us to think a lot about 2 things: keeping the cost down and making sure that the quality that we deliver is excellent. And so we don't want to be doing revisions. We want to be doing one joint replacement, and we want that to last the rest of your life. And so we have to think about what are the things that we can do to make that more likely. And, you know, just some statistics, you know, there are about 4.5 million Americans living with total knees right now. 63% of them are women. Huge increase since the mid-90s in the incidence of this. The reason for that are twofold. One, we've all gotten older. Number 2, the indicated age for doing knee replacement has gone down. When I did my residency at Bethesda, it would be very unusual that we would do any type of joint replacement on anybody younger than 65. Now I would say the average age of my population to do a joint replacement is probably about 63, and I think that reflects the fact that people don't want to live in pain when they're at a period of their life where they want to do things and have a higher quality of life. So that's changed a lot. But you can see it's the 4th highest reason for hospital stays in the country, and the annual cost is about $9 billion, so very, very expensive. And you can see where this is going. So this is a slide that depicts the trajectory of primary or first-time knee replacements and then first-time hip replacements. And, you know, the numbers are not important. What's important is the trend. So you can see that there's going to be an escalating demand for these surgeries as we go forward. And that's going to have some very significant public health and public financing implications that we'll talk about a little bit as we move on in the future. And I think it's why we all have to be a little bit politically savvy as we move forward. Now, the other concern we have is not only are first-time joint replacements escalating in frequency, but the redos are as well. And it's estimated that the total cost to revise a total knee, so say you have a total knee, say it gets infected. That happens. There's the incidence of infection is anywhere from about 2 to 5% in the United States. It's a lot less here, but the cost of taking care of an infected total knee is about $100,000. Okay, so that's huge. Okay, and a very big concern from insurers and especially Medicare when it comes to that. So let's talk about how you can treat arthritis just in general. We talked about what arthritis is. What can you do about it? Well, certainly diet and exercise, and a very, very common question that I'm asked virtually every clinic is, I've gained a little weight and that's why I have arthritis. Let me dispel that. Okay, weight does not cause arthritis. Okay, weight can make arthritis more symptomatic, but weight does not cause arthritis. So don't beat yourself with that. And so, but we do tell patients you'll probably be a little less symptomatic if you can lose a little bit of weight. We all know that's easier said than done, but that's true. Exercise, I think, maintaining the range of motion of the joint, whether it be your knee or hip, is very, very important because typically the better you are before surgery, the better you're going to be after surgery as far as range of motion. Medications, we talk about anti-inflammatories, Aleve, Advil, Mobic, all those medications, can be very helpful in alleviating some symptoms. Obviously, they don't change the underlying fact that you have arthritis, but they reduce, basically what they do is they reduce the inflammatory response to arthritis. So they're helpful. Again, they're not meant to anesthetize you. They're just to reduce the pain so that you can do things. Physical therapy has a role for sure, both in strengthening and in maintaining range of motion. I think that's very important. So I think physical therapy definitely has a role even before surgery. Arthroscopy is a procedure that many of you have probably had where we put a scope in a knee. Sometimes we'll do it in a hip. We do it rarely for hips for arthritis. Now, arthroscopy used to be something we used to do very, very commonly. People would have arthritis in the knee, and we would say, tell you what, let's scope it, let's clean it out, and that'll help you. And there were 2 huge studies that were done on this that have been published in the last 5 years that looked at thousands of patients, and they compared the results of arthroscopy just to clean out the joint and relieve pain to either doing nothing, placebo, or injecting cortisone. No difference. And so arthroscopy simply for arthritis is probably contraindicated now. So most people don't do it. Sometimes we'll do it if you have a loose body in your knee or if your knee is locked, you can't straighten it, we'll do it. But that's usually not an option that we will recommend for knees at least. Injections, we're going to talk about them at some length. And then, so those are the conservative things. Pretty much, injections, anti-inflammatories, activity modification, which means changing what you do, physical therapy, they're all the conservative treatments for treating arthritis. And then when that doesn't work, then we'll talk about partial joint replacements and total joint replacements as we go. But then again, there's always Australian dream, so these crack me up. I used to have a slide, remember the willow curve, that was on TV, and Chuck Lowry pushes all these things. He's like the pusher of these things. But Australian dream, I looked at this at Walgreens once, and it costs like $40. I mean, it's just crazy. So let's talk about injections. So we get asked this, again, virtually every clinic, So what are the things you can inject in a joint? Okay, well, there's cortisone, there's hyaluronic acid, which is that gel shot that you hear about. We'll talk about that. There's what we call platelet-rich plasma, and then there's stem cell therapy. And if you listen to Chicago radio at all, you're hearing a lot about stem cell injections, and I really do want to dispel some real myths about that tonight. So cortisone, super effective, super cheap. Usually patients will report that they get relief in anywhere from 2 to 5 days. But the duration of relief is variable. So patients always ask, Dr. Edwards, how long can I expect this to last? And I always say 2 weeks to 2 years, because that's my experience, you know. So there's no definite answer to that. But I would say most people get fairly decent relief of pain with cortisone injection. But cortisone has its own issues. You know, cortisone can unbundle collagen. So just think of cartilage as a quilt, okay? What cortisone does is it unbundles the quilt, okay? So actually, if you get too much cortisone, you can actually accelerate arthritis. And cortisone can also set up an environment in a joint that makes it a little more susceptible to infection. So there's a very good study that came out at our major meeting last year in New Orleans, where they looked at a little bit of an increase in infection rate in people that had had hip injections within 3 months of a hip replacement. So I would say in general, we don't do any type of surgery until we've let that settle down for about 3 months. So I'm having a lot of conversations this week with patients saying, you know, I don't want to have a knee replacement or a hip replacement done this summer. But I don't want to live like this all summer. So there's a lot of, we'll do your injection, but, you know, we can't really talk about surgery until like September. Okay, so that's cortisone. Cortisone's terrific medicine. We typically tell patients that we limit it to an injection every 6 months, and we try to limit it to no more than 3 in your lifetime. There are always exceptions to the rule. One thing you learn as you turn 60 is that you never say never and you never say always. So let's talk about these gel injections. These gel injections are what we call hyaluronic acid derivatives. And basically, they come under a bunch of brand names, Synvisc, Hylian, Suparts. And hyaluronic acid is actually a normal component of joint fluid. And basically what these injections do is they add in joint lubrication and load transmission. So they're really expensive, and they usually require multiple injections. I give 3, some of my partners give 5. One company had a product that you could give 1, but all it was 3 injections in 1 syringe. I did that twice, you know, that was the end of that because patients hated it. But relatively expensive, and I think the biggest concern we have is it's a very safe medication, but I think there's a lot of debate about the efficacy. Is it really that helpful? And a lot of studies have been done that really haven't shown that it's that much better than placebo or cortisone injection. And so for a while, Blue Cross stopped paying for it this year, and Medicare wasn't paying for it. The Mayo Clinic has stopped giving them. So again, they don't hurt you, but it's just, do they work? And when, you know, we're in an era where you're going to hear this term as you go forward in your lives with every medical specialty, and it's going to be called evidence-based. Is there evidence that justifies you doing this injection, giving me this medicine, doing this operation? Though that's a very important term to understand. So there's very little literature that supports repeated administration, but I can tell you, I've got patients that swear by this stuff. You know, they've had it, it worked, and, you know, when I tell them, you know, the literature doesn't support it, they say, terrific, give me an injection. Okay, so that's that. I do want to talk about stem cell stuff because, you know, there are some things in medicine that really infuriate physicians. And one of them is really misinformation, fraud, and taking advantage of patients. And this is, in my mind, on the top hit list in the city of Chicago right now. So basically what stem cell transplant, you know, we all hear stem cells, and we've, you know, been listening about stem cells forever. You know, remember George Bush had to give a talk from the Texas ranch about stem cells, embryonic stem cells. But there are a number of physicians in Europe and now in the United States that are giving stem cells. And basically what you do is you take some blood from people, you spin it down, you take away the stem cells, and you inject them into various joints. And I can tell you, I'm a product of a successful stem cell transplant for multiple myeloma, but you're not putting it in my knee because there is, these are just quotes from various articles. Stem cells for knees, promising treatment or hoax. There is no FDA approval for this treatment in knees, And here's what really I think we should look at. The New England Journal of Medicine this year published an editorial that FDA officials warn the lack of evidence for unapproved stem cell treatments is worrisome. So, here is where we're doing things to patients. You have to pay cash for this. It costs you about $5 or $6 grand to get this done. And there is not a shred of evidence, peer review evidence, that demonstrates that this is effective treatment. And I get asked about this every clinic, every single clinic. So stem cell treatment is, in our mind, a farce at this point. So, I think a great way to think of it, we talked about arthritis as a loss of cartilage over bone, so bone rubs on bone. So the theory of stem cell treatment is that you get it and somehow you regenerate cartilage. Well, that just metabolically cannot happen, but people are profiting from it, and it's very troubling when you see that allowed to continue. So at the end of the day, if conservative treatment doesn't work, you've done all these things, you've gone to Chicago, you've gotten your stem cell injection, and it doesn't work, who becomes a candidate for joint replacement? And I have Edwards 4 criteria to get a joint. Okay, 1, you have to have x-rays that show you have arthritis. Number 2, you have to be healthy enough to do it, and that's optimized medical status. Number 3, you have to have at least tried and failed conservative treatment. I think if you go to a doctor's, 2 things I would warn you about. If you ever go to a doctor's office and they say, I'm the best at this, run out of the office, okay? Because I can tell you in the United States, orthopedic surgeons are extremely well trained, and our training is extremely standardized. So I do a great total knee, and I do a great total hip and a total shoulder, but I can tell you my partners do great total knees and total hips and total shoulders. And so beware the boastful physician, okay? So that is one thing. The second thing is that if you walk into a doctor's office and they throw up an x-ray and they walk in and say, oh yeah, you need a knee replacement, and walk out, join them out the door, okay? Because A, you don't know what the hell the operation is, B, you haven't tried any conservative treatment. So operative treatment is not the first treatment in general for that. So you have to try non-operative treatment, and ultimately it has to be affecting the quality of your life. So I can show you some horrible x-rays of people who feel great. It's a little sore. If I walk 5 miles, it hurts. Well, you don't need a joint replacement if you're walking 5 miles. But they're not really, it's not affecting quality of life. So we don't expect you to be on your hands and knees crawling into the office to get a joint replacement. But on the other hand, if you're saying, hey, I can walk 3 to 4 miles a day, if I take a leave, I don't have any pain, your x-rays can look horrible, but you don't need a joint replacement. Okay, so that's sort of the criteria that I think is sound to use. Now, when we talk about surgical optimization, this is something that's really changed. We used to do all comers. Okay, you came into the office, you met the criteria of x-ray, tried conservative treatment, and that, we would do your surgery. But as we talked about, with the enormous number of joint replacements that are being done in the United States, we need to make sure you have a good outcome, okay, because of the cost of revision and the horrible going through revision. Going through revision is terrible. So we've really devoted a new emphasis nationally, this isn't just in St. Joe, nationally on smoking, weight. So BMI is just a measure of height and weight, and hopefully you're all tall and this. But BMI of 40 is a pretty strict criteria. I would say BMI of 45 is now sort of the national cutoff. That doesn't mean that there aren't some patients that are a little heavier that we do. But in general, we're looking for BMIs under 45. Physical deconditioning. We see a lot of patients that you can look at their x-rays and say, I can make that x-ray look better, but they haven't walked in a while, they haven't done stuff in a while, and that's where our physical therapy colleagues come in to try to optimize them beforehand. If you have diabetes, that hemoglobin A1C that you hear so much about, there is such a relationship between elevated hemoglobin A1Cs and postoperative infections in total joints that we take that very seriously. COPD, which is respiratory problems, usually from smoking, but it could be from other things. Alcohol abuse. And preoperative narcotics, you know, in Michigan this week, we just started a whole new paradigm in how we have to prescribe opioids. You know, we can't prescribe opioids the way we used to prescribe them last week. It's totally different, but it reflects the national concern we have on people taking too many meds. So we feel, orthopedic surgeons feel very strongly, that it's probably inappropriate in most patients to treat arthritic pain with Norco, Percocets, things like that. You know, we really need to treat the problem before we start creating opioid problems for patients. So, and then there are a lot of things we've learned over 25 years here about, you know, what makes a successful program. One is standardization. We want to make sure that I'm doing things the same way that Dr. Loafman and Dr. Sohn and Dr. Sabizma and Dr. Farber and Dr. Burzak are doing things. We want to be accountable. So the days of sort of hiding about your own data have gone. I mean, I can tell you, we're confronted with our own surgical results every month. Okay, we know exactly how we're doing. And the good news here is our data is unblinded. So I know how I'm doing, I know how Nick's doing, Nick knows how I'm doing. And it's not to punish us, but it's to say, hey, you know, we seem to have a little issue here. How can we get our heads together to make it better? All to make your experience better. Medical optimization we talked about, a team approach. We have a phenomenal coordinated team between therapists and surgeons and anesthesiologists, and innovation. That doesn't mean you do every new fad, but it also means I'm not doing knees now like I did them in 1993 when I arrived, or I'm not doing hips the way I did them then. So that's very important. Now, we're very fortunate in Michigan. I don't think people realize what a phenomenal state we live in. I mean, it's the best kept secret. You know, we got the best natural resources, we got the most water, nicest people, but we also are very blessed to have a registry called Marquee, which is basically what a registry is that every single case that we do gets recorded in a regional registry kept in Ann Arbor and run by the University of Michigan, and all that data is put together. And every quarter, I go to a meeting as our representative to look at the quality data in the state and to look at the quality data at our own institution. There is no other state in the United States that is looking at the quality of joint replacement more closely than Michigan. And this is true whether you go to Kalamazoo, Grand Rapids, Ann Arbor, Lansing. So the theme of Marquee is we want to make Michigan to be the best place in the world to have a joint replacement. And you can say that, they're easy words, but we actually have the data and we're scrutinizing that. I'm going to show you some examples. And this is just a picture of the hospitals that are involved, and so we're sort of down in the corner here, but it's really quite a privilege that we were invited to join Marquee. And let me show you some of the things that Marquee has resulted in. This is a result of the number of transfusions that are done in the state as a result of that. And what you can see on the upper left is we were given a lot of blood transfusions to patients in the state when Marquee started in, I think that those data is from about 2012. And if you look in the lower right, you can see the progress that we've made. And the reason that not giving a transfusion is important is there's a higher risk of infection to patients if they get a transfusion after a joint replacement. So we've done a ton of things to reduce blood loss and to make sure that we minimize the use of blood transfusions. You look at infection, the trend line is the same. And I can tell you that the infection protocols that I use here are the same ones that they use at the University of Michigan, the same one they use at Spectrum Hospital in Grand Rapids and in Bronson and Borges. So we have really united in a statewide effort to reduce the rate of infections, and the rate of infections in Michigan is way lower than the rate in the rest of the United States. And we look at readmission rates, it's the same trend. So readmissions, obviously when we talk about cost effectiveness, we want to make sure that you don't come back to the hospital over and over again, because that escalates the expense of doing joint replacement. And also it's a reflection that there have been problems as well. So there are just three examples of how our participation in this statewide collaborative, which is very accountable. I mean, I get my data every month, how I'm doing. I get Lakeland's data every month, how we're doing, and we're compared to every hospital in the state of Michigan. So now we're going to move on. I'm going to talk specifically about knee replacement, and then Dr. Loafman is going to talk a little bit about hip replacement, and then we're going to answer your questions. So again, let's go back to knees. Normal knee on the right, lots of space. Arthritic knee on the left, no space. That's what arthritis is, and we're assuming people have done all their conservative treatment. And this is our goal. Our goal is to have satisfied patients, very comfortable, satisfied patient. I'm happy to say my incisions are a little smaller than that now, but it's not about the incision. And so what is a knee replacement? Basically, I think people have a tremendous misconception generally about what a knee replacement is. People think that when you do a knee replacement, you basically cut off part of the thigh bone and cut off part of the shin bone, take that out and put some modular thing in. I think a better way to think of a knee replacement is think of it as a knee resurfacing. So we talked about there are 3 surfaces in a knee. There's the kneecap, the thigh bone, and the shin bone. And what we do is we remove a little bit of bone from each of those surfaces and we replace them with metal and plastic components. So here's an example. What we do in the upper left-hand slide, that's the femur of the thigh bone. We have specialized computerized instruments that allow us to make that exact cut. I'm going to talk about that in a little bit. And so we remove about 10 millimeters of bone. That's about that much, okay? So from the end of your femur. And then we put a piece of metal on the end of it. Typically, we secure that with bone cement. On the tibia, we make a straight cut where we remove about, 8 to 10 millimeters of bone, and we cement a metal component, and on top of that metal component is a plastic liner of a material that's called very high molecular weight polyethylene. And then on your kneecap, we remove about 10 millimeters of bone, and we cement a plastic button. So most people keep their entire kneecap, or most of their kneecap, and it's just replaced with a little button on it. And so when we're done, the first dividend of a knee replacement is your knee is straight, and it's more stable typically than when you started. And then once you've recovered from your surgery, the pain goes away because you're no longer a bearing bone on bone, you've got metal on plastic, okay? And that's why the pain goes away. So this is just a picture of what a replaced knee looks like. You can see how nice and straight it is, and if you look, that's a pretty good result. So one of the things that's fairly unique to what we do here is we were searching years ago for what are some of the things that we can do that can get rid of the variation among surgeons and even among the same surgeon when they're doing various cases. And so one of the things that we discovered is computer-assisted surgery with computer navigation. And basically the whole goal of this is not some robot comes into your room and does your surgery for you. This is basically what are the tools that we can employ that make sure that the knee I do on you is the same that I do on you, and that the results are very reproducible, okay? And the thought is, if we can put the joint in as perfectly as possible, that the likelihood of it wearing out should be reduced theoretically, okay? And so what we do is we use computer navigation. It's a Stryker product. That's not important who makes it, but basically it's sort of like a GPS. So basically what we do is we have different trackers in the operating room. We enter various anatomical points of your knee into a computer, and it gives us guidance on how we make our cuts. And these are some of the pieces that we put in. It involves a computer, an infrared camera, fixed beacons, and we use it on a lot of our cases, and it's really, really helpful. It's very helpful in a knee. I was talking to one of my partners the other day. We were just reflecting on this, and it's somebody I've been in practice with for a long, long time. And he was saying, we were talking about the benefits of it, and he was saying that he has noted very specifically an improvement in the alignment of his knees. And he's not a very emotional guy. He's very matter-of-fact, very scientific. And I was struck by that. Where Nick is going to talk a little bit about the use of it with hips, it has totally improved how myself and my partners put in cups for total hip replacement. So it's very valuable, and we're the only institution around here doing it. But then there's also another exciting innovation in knee replacements, and this is called patient-specific instrumentation. So what we do with this, and Dr. Loafman is very skilled with this, what we do is we do some imaging, a CT or an MRI of your knee, and basically you get jigs that are made for your bone very specifically. And this is another way, again, of reducing that variability that comes from us just thinking things look good. We have very objective things that tell us that things, in fact, should be very specific. And then a little bit about partial knee replacements. Again, this is a question I get asked every clinic. What is the indication for partial knee replacement? Well, partial knee replacements are indicated very specifically if you have arthritis only in one side of your knee. And in general, it has to be the inside of your knee. There's been a resurgent interest really over the last 10 to 20 years with this. Small incision, but it's not indicated for everybody. You really have to have a minimal deformity for this. And I think we're noticing in the marquee registry, I told you we register every case and we look at how are people doing with this. I think there's a little concern about the long-term results of partial knee replacements. Not all of them are failing, but I think there's a little bit of concern about that we as orthopedic surgeons may have extended the indications a little bit in our enthusiasm to do them. And I think it's caused all of us, certainly in our practice, to really look very carefully about who are the best patients for this. In general, it's great for older, thin, less active patients. But I think this is evolving as we speak. So how do people do? What are outcomes? This is my daughters, my wife and I went to Australia and to New Zealand, and my daughters convinced me to do a bungee jump. So that'll take a look. That's the only one I'm ever doing. So I want to talk a little bit about outcomes, but I also want to talk about expectations. So we have learned in the United States that with total knee replacements, when we started asking patients, how do you feel? We come out of surgery, we look at the x-rays, we high five, we're terrific, we're great. And you ask somebody, how are you doing at 3 months? And they say, crappy. I'm not feeling so good. And I think that it's really caused all of us in orthopedics, but particularly in Michigan, where we're looking at patient-reported outcome, to look at what is the message we're delivering to patients. And I think we've been a bit enthusiastic. So, so when you look at total knee replacements, patients are bombarded with information and images that say, you're going to be, after 2 weeks, you're going to be on the parallel bars like this gal, or you're going to be running a marathon like the gal on the left. And I think what that does is that gives patients perceptions that you should be normal after 6 weeks, or you should be, you shouldn't have any pain, or you shouldn't have any discomfort. And I think that, there are a couple of things that predispose people just in general to dissatisfaction. Preoperative narcotic use, you can read this list here. But I can tell you the biggest thing that predisposes you to dissatisfaction is your surgeon hasn't spent enough time with you explaining what you can expect after surgery. Okay? So here's sort of what I tell people. You're going to be in the hospital anywhere from 0 to 2 days, typically. Okay? We'll talk a little bit about outpatient knees. I call the first day the honeymoon. Now, many of you are married, and we realize that honeymoons don't last, okay? But that first day is a great day. And the reason it's a great day has very little to do with me or Dr. Loafman, has to do with our anesthesia friends. And, so typically with the total knee, we do the majority of total knees with a spinal anesthetic, and we also do something called a block, and we also give you an injection in the knee, and you also take medicines before you go to surgery. So we're great. We are great at eliminating pain that first day, okay? And that's a real advantage to you all, because that allows us to get your knee moving right away. It allows us to get you walking the first day. And honestly, if we can get a head start, you're going to do terrific. And I would say your length of stay likely is going to be just overnight. But some people stay for 2 days, and that's not a crime. The most important thing is that you go home safely. But I tell people 2 things about total knees. First, this is an operation I do with you, not to you. Okay? So if you have to have your appendix taken out, you don't have to participate very much in that. But if you're having a total knee, we'll put everything in right. I've just shown you how we make sure we put it in right. You've got to make it work. Okay? And so it's an operation I do with you, not to you. And the first 6 weeks are for the birds. Okay? The first 6 weeks are get the therapy, get bending, get walking, do all the things you don't really want to do. But that 6-week period is extremely critical in regaining your range of motion and getting on your feet and walking. But I think what's really important is to understand that people with total knee replacements continue to improve for 12 to 18 months postoperatively. So on a very positive note, things continue to get better and better and better. So you're going to be better at 3 months than you were at 6 weeks. You're going to be better at 6 months than you were at 3 months. You're going to be a lot better at a year than you were at that. And ultimately, the question that I think is important is not, are you pain-free? It's compared to the pain that you had before surgery, how do you feel now? People don't even let you finish the sentence in general. So knee replacement can be, you can have certain things with knee replacements. Again, if I don't talk to you about these things, you think there's a problem. Clicking, we talked about how on the kneecap, we put a little plastic button on the kneecap. Well, that rubs against the metal on the end of the thigh bone. Everybody gets clicking after a total knee. It's not a problem, it's just how it is. Most people get numbness around the incisional area. Again, not a problem, just the way it is. But if I don't tell you, you're going to think there was a problem. Difficulty with kneeling and squatting. When I tell you that people continue to improve for 12 to 18 months, I think the last thing that gets better are those 2 things. Getting up from a squatting position and kneeling are the 2 things. Everybody asks, can I kneel after a total knee? And really what you're asking is, am I going to do irrevocable harm to myself by kneeling? Well, the answer to that's no. Is it going to be sore? There are just some patients that are very uncomfortable kneeling after a knee replacement. So, you get a pillow, you get a... my wife has some problems with knee arthritis, and the other day I went on Amazon looking for a kneeler for gardening. Oh, my God. 242 kneelers for gardening, okay, which means we got none because I couldn't make up my mind. And I think at first you're going to notice you'll have a little slower walking speed after a knee replacement. But I think in our enthusiasm to get you to sign up for surgery, I think we've been guilty of not spending enough time really warning you about what you need to do to have a good result after a knee replacement. Now, Dr. Loafman's got the easy job. He gets to talk about hip replacements where people get off the table and start running around. But knee replacements are a different operation than hip replacements, and it does take time to get better. Having said that, this is a great operation. Okay, this is an operation where 93% of patients are satisfied at 5 years, consistent reduction in post-op pain, and gradual improvement over that 18 months. And so patient-reported outcomes, if you come to our practice to have a joint replacement, you get sick of forms. Oh my God, you're so sick of forms. You have to fill out forms for your insurance, and now we're giving you more forms. And it's, how do you feel? And so what we want to know before surgery is we want to know what are your limitations, functional limitations, how do you feel, things of that nature. And you're going to get intermittent forms throughout your post-operative course with us. And we put that all together. That goes to Ann Arbor. And we look at that. And it's no surprise that people that didn't have a lot of pain before surgery, but may have had lousy looking x-rays, don't really improve that much. Okay, and I think that's a sobering moment for us because it's another one of those patient selection criteria. We have to make sure we're operating on the right patients. Not only are they healthy enough, not only have we prepared them for surgery, but really, are they having enough pain to really justify doing these operations? And I can tell you, this is going to be an escalating demand from Medicare and other payers in the future. This is our future. There's no doubt about it. That's where things are going for sure. And the joints do great. They last. So I think people worry about 2 things with total knees when they come to see me or total hips. One is it going to hurt? How are you going to manage my pain? Number 2, am I going to have this operation again? There is a real common misconception among patients that if you have a joint replacement, you're going to have it redone at 10 years. I don't have the foggiest notion where that came from, okay? But I can tell you the facts. Total knees, the survivorship, which means how many of these are still functioning at various intervals. At 20 years, it's 97%. I can't think of anything in medicine that lasts that long. Total hips, about 85 to 90% now. Total shoulders, about 88%. So these are very durable surgeries that last a long, long time. I feel very confident when I do knee replacements on almost any patient, or a hip replacement on almost any patient, that I can comfortably say, I expect this is going to last the rest of your life. Okay? We don't do surgeries to do surgery and then tell you you're coming back in 10 years to do it again, for sure. So what does the future hold in my mind? There is a market push for outpatient surgery. Okay, now any of you that have had knee replacements, I would dare to say I've met very few of you that said, I'd like to go home right after that operation. However, this is something that's being looked at. It's done right now for marketing purposes, but I think this is going to be a push from the payer as well. Right now, I get a nag notice every time I do a knee replacement on that first post-operative day that you've got to discharge the patient. Every single day, and it's not because the people are mean at Lakeland, but that's Blue Cross or Medicare saying you don't meet inpatient criteria. And every day I keep doing my work and ignore it and move on. But someday I won't be able to. Obviously, we've talked there are going to be a lot more patients. There's going to be a much greater cost burden to the health system in a system where costs are out of control. I mean, just to give you some reference, okay, the gross domestic product that we spend on healthcare right now in the United States is 18%, compared to the nearest competitor, which is Switzerland, 11. Okay, so something's going to happen with healthcare. Nothing's going to happen with healthcare for the next couple of years, but when this fun is over, it'll change. We're going to have to justify who we're doing surgery on. We already see that. You hear about authorizations, pre-authorizations. It used to be checking your insurance. Now it's going to be, did you do bink, bink, bink preoperatively? What's their PROS score, et cetera. We're going to see more revision surgery. And I think for younger patients with early arthritis, we're going to see tissue engineering and biologics. I don't think that's going to be for most of the population that we're talking about today, but I think that's what's going to happen in the future. We'll wait for questions to the end. The question here is, why did Sergio Garcia keep hitting golf balls into that body of water? And that was the ship I served on for years. So that's that. And it's my privilege to introduce Dr. Loafman to you. Nick is a wonderful addition to our practice. We're blessed to have him, and we just have to mic up, and he'll get started with hips. Okay. So this one is for the recorder. All right. Can everybody hear me okay? All right, great. That was a great talk, Ken. I hope you guys learned a few things. I know I did. It's always good to, hear information. Anyway, a little about myself. I'm a Michigan native. I grew up in Montrose, Michigan, which is a few hours north of here. I went to college at Albion College, just east of here. Went to medical school in Pennsylvania, and I did my surgical training in the Chicago area. And kind of like Ken, ended up right back in Michigan here, not too far from Chicago where I trained. So, see a few familiar faces in here right now. He talked about total knees, and I'm going to talk a little bit about total hips and a few things that go along with it. And like he said, it's kind of it's a joint replacement, but it's a completely different operation. And we'll get into a couple of those things here. So like he talked about, what is a total hip arthroplasty? And I get this question all the time from patients in the office. What's the difference between an arthroplasty and a replacement? It's the same thing.
You just see the words everywhere in the literature, in the papers, or on TV, but it's exactly the same thing. And basically we remove the damaged bone surfaces and we replace it with prosthetic components consisting of metal, plastic, ceramic, and other things. And you can see the x-ray up here. On the left, that's essentially normal. On the right, that does not look normal. And then on the far right, you can see what a total hip replacement looks like. Those are real x-rays. So total hip, the first one was performed in 1960. And since then, we've gotten a lot better at them. And right now, it's actually one of the most successful surgeries performed, I think. And it has something called the forgotten joint score, or when you compare hips to knees or shoulders, a lot of patients sometimes they forget which one they had replaced. And that's essentially a forgotten joint. Okay, and so that's the goal. And we're trying to replicate that in the knees and shoulders as well. But for right now, hips, people seem to forget that they had a hip replacement a lot of times. Not everybody, but a higher percentage in hips than knees and shoulders. And so that's a good thing. And I think that's indicative of how successful the surgery is or can be in people. And Ken talked a lot about this, about the advancements and improvements. And there's this huge push right now to do outpatient total hip surgery. The big cities are pushing it. A lot of private practices are pushing it. And I think some of that is, misconceived. I think they're doing it at a surgery center that they have overnight capabilities, so they stay overnight and they call it an outpatient surgery because they were there for less than 23 hours. I don't perform those. I kind of like having my patients in the hospital for a day. I think when all the bad things happen, usually that's when it happens, is within that first day, and I think the best place to be is in the hospital. So with that said, I have patients coming asking for it all the time, and I'm sure, as he said, insurance and other cost factors are going to be driving that more and more. But right now, it's not something I do, but most people go home the next day. They get up with therapy, they walk around, they do very well. They're pretty happy, and like he said, the recovery is much better for a hip than a knee typically. And that's why we all like to do hips more than knees. And he had the same statistic, most of them, 85%, are good for 20 years at this point. And I think that's some older data, and I think the idea is the stuff we're putting in now is better than it was 20 years ago. So hopefully the new stuff is going to last longer and longer, or provide better outcomes. Like he said, 300,000 to 400,000 hip replacements are done yearly, and I think that's going to continue to climb, much like his statistics showed. So the anatomy, just like he kind of briefly mentioned before, it's one of the biggest joints in the body. It's a ball and socket. It's round, so the motion is a little more fluid and a little bit, I think, better and easier to recreate when you replace it compared to some of the other joints. And I think that's another reason why we have better outcomes. What it consists of is a femoral head that fits into a socket called the acetabulum. And like he mentioned, there's cartilage on both ends of those surfaces. And the reason everybody says, well, why did all of a sudden did I start having pain? I've had arthritis that shows on X-rays for years. It's just getting worse. So why is the pain increasing? And what we know is that on the ends of the cartilage, there's essentially no pain fibers. But as that cartilage wears down, underneath that cartilage on the surface of the bone, that's where there's pain fibers. And so when those bones start rubbing on each other, we start to feel the pain more. And so that's why all of a sudden it starts hurting more. Or people come in, they have a terrible X-ray, and they say, well, how come I never felt this for years? How all of a sudden could I have arthritis overnight? Well, they didn't have arthritis overnight. It just slowly progressed until they were feeling those fibers on the ends of the bone. So why do people get arthritis? From general wear and tear? Yes. Is there a genetic component? Yes. There's several other reasons why people get arthritis. Several rheumatoid or other chronic inflammatory conditions. People have been in traumatic accidents where they have damage to the joint, and that continues to progress. Sometimes, we have medical conditions that lead essentially, the ends of the bones to die, and avascular necrosis is a common one in the hip more so than anywhere else, but can also happen in any other, bone in the body. And then childhood hip conditions where the anatomy is not quite correct or they've had previous injuries leading to a deformity. There's other ones, but these are just probably the most common. So this is the thing. Who should get a hip replacement? This is what we talk about in the office all of the time. And who makes that decision? And a lot of patients come in and they really want us to tell them. Like they say, well, do I need one? Should I have one? How come nobody will tell me I need one? You know, and well, we don't want to tell anybody to do anything. We want you to come to that conclusion yourself. And so this is something that, you know, we hope that you're familiar with it. You've come to these lectures. You've had this conversation with your friends, your family, your primary care physicians. So you're well versed when you come in. And then we can really elaborate on what he talked about with some of the more of the procedural type of things to kind of ease your mind. But this is a community decision made by you, your family, and, you know, the people that know you the best. And sometimes it kind of helps you think through it and make a good decision. It's not just throwing up an x-ray and saying, oh yeah, there you go, you need it. And like you said, we don't treat x-rays, we treat people. And a lot of times, you know, you can come into a room and see, you know, 2 hips up, and immediately you think it's the bad x-ray that you're going to be treating. They say, oh no, that one doesn't even hurt, it's the other side. And so, you know, and that happens in every joint also. So, you know, we don't treat x-rays, we treat people, and we try to make good decisions. And like he talked about, the ages, most people, 50 to 80, but there's been numerous studies that, you know, hip and knee replacements is, you know, people in their 90s, people 100. I mean, some people younger than 50. It's not uncommon. We are kind of stretching the indications, and we're putting them in younger people due to better joint services, better technology, and people, you know, want to enjoy the quality of life while they're young. So we are kind of starting to do things a little earlier, and we're hoping that that doesn't come back to haunt us. You know, medical history, like he said, you know, being an appropriate candidate, and those several of the things that he talked about earlier. I like people to have, you know, chronic symptoms or pain that has been present and progressive for a long period of time. You know, something that comes on quickly, you know, sometimes can be misleading or present as something else. I think it's important to kind of take the time to figure out exactly what's causing the pain. Usually, you know, we have evidence of well-defined arthritic changes. It kind of matches up with the things that you come in the office and to say, and the treatment options that you've tried. And then we kind of know that the pain is coming, you know, from that joint specifically, and not being, you know, caused by something else like your back or, you know, a vascular or nerve injury or something like that. So we want to make sure that we have the appropriate diagnosis. And then you've exhausted conservative treatment, you know, whether it's anti-inflammatories. And in the hip, we don't quite have as big as an armamentarium as like in the knee. So we don't do as many injections. You know, we do ultrasound guided injections, but we don't have any of the gel shots. Those things aren't appropriate for the hip. Nobody's really pushing stem cells or platelet plasma. None of that stuff is really getting pushed in the hip as much as it is to the knee. And it just hasn't shown to be beneficial. So I think when it's time to do something for the hip, I think the basic treatments have failed, and there's really nothing else to try. I think that's time. And so, when do we have surgery? Now you've decided to have it. You think you need it. You come in, you have appropriate x-rays, everything matches up. So, people come in with hip pain and they say they've lost motion. They have a hard time getting in and out of the car, going up and down stairs. Similar with the knee, they've lost a lot of motion, and they're starting to notice, you know, they have pain in their groin more posteriorly. You know, simple things as putting on shoes and socks is a big thing. It's a nothing thing until you can't do it. And then all of a sudden it's a big thing. And I think many people come in and they say, I just can't put my socks and shoes on anymore. And that's pretty good indicator that it's definitely their hip pathology that's causing their symptoms, and it may be time to do something. A lot of times we exhaust physical therapy, because if you start to get a painful joint, that pain can be exacerbated if you do nothing. People think rest and do nothing, but that can actually, you know, increase the stiffness, which can increase the shear forces in a joint and make things worse, where a lot of times we can try physical therapy. And a lot of people say, well, why would I do physical therapy if I'm going to need a surgery eventually anyway? And it's like you talked about before, you know, doing surgery after you do therapy, or what we call like a prehab, it actually can make your post-surgical, you know, course much better. You can have a better long-term outcome if you do a lot of physical therapy to increase your range of motion, strength, and functioning before you have a surgery. So I think that's an important component that I think we're starting to notice more and more, and that we're going to start incorporating more and more into our practices. So I'm sure many of you have had an orthopedic evaluation. If you haven't, what does it consist of? It means coming into the office, we take your medical history, We do an exam. And typically, we review your x-rays with you or other tests, MRI, CTs. A lot of people come in with MRIs or CTs, and I think we can get just as much information from a basic x-ray. And we kind of review those things and we correlate everything. We don't just base it off of one thing or the other. We like to put the big picture together and make a good decision. So now you've decided to have surgery. What is actually going to happen? And this is the surgical component where we remove the damaged part of the hip or the surfaces and we replace it. And we put a cup into the acetabulum and then we put a stem down in the shaft of the femur with a surface that has a ceramic and plastic, surfaces for better smooth gliding surface. So when it comes to the hip, there's 3 main approaches, and this seems to be a big topic right now, and a lot of patients come in and ask about the different types of approaches and how to go about it. Traditionally, the posterior approach has always been the most common, and it's the gold standard. It is definitely still the most commonly performed. Guys have been doing it for a long time. It's very reproducible. Initially everybody thought that it wasn't as good as some of the other approaches due to instability or bigger incisions and things like that. And what we found is, the approach long term isn't as important as how you put the components in. And that's where some of the newer technology comes into play. And then there's an anterior and a lateral approach, and the anterior is definitely the newest way. Luckily in my training, guys were starting to do it about 10 years ago in the Chicago area, and so I learned it and I incorporated it into my practice, and that's definitely my preferred way to do it. And I think the reason why a lot of people come in and ask about it is they hear about things about faster recovery, smaller incisions, and I think there is some truth to some of that, but I think maybe there was initially a lot of truth to that, and I think it forced guys doing the other approaches and techniques to get better. So I think now they're becoming closer and closer, and I think they're all getting better together. All right. So, and I stole this from Ken. I don't know where he is. It's one of his lecture slides. So if you type in Google, what does it say? Anterior comes up a lot, and people rave about it, and they think it's the best. And I certainly prefer it. I do a lot of it, and Ken does a lot of it, and I think the patients do well, and it makes me feel better from a dislocation standpoint and some other things that we'll talk about. Here's another slide I stole from Ken. That's from Marquis. And who's doing what. And you can see, initially in 2012, most people were doing posterior approach. And that's definitely on the top there. And that's come down a little bit, and it's kind of leveled off. And I think the anterior approach is the green on the bottom, and I think there was some excitement and guys started doing them, and I think that's kind of leveled off too. And I think eventually it'll kind of slowly work its way, but I don't think that it'll always be one or the other. I think guys will continue to do multiple different approaches on different patients, and then the anterolateral one's kind of there in the middle, and I think that's becoming less and less popular. So what is the anterior approach? Everybody comes and asks, what does that mean? Well, we do make an incision more anterior on the hip. And is it less invasive? And I would say yes, to some extent. I think it is a less invasive way of doing a total hip replacement. And that has nothing to do with the incision size. I don't think incision has anything to do with how invasive a surgery is. I think it's what happens underneath that incision that's important. And in a true anterior approach, most of the time you're able to do a surgery without cutting any muscles. You're able just to kind of move them out of the way and create access to the hip so you can put a hip in and just let everything kind of close over it without causing any major structural damage. Now in the other approaches, I think you still have to take some of the muscle with it. And they're getting better and better, and they're doing some sparing techniques, and they're not taking near as much muscle or cutting near as much, and their incisions are getting smaller. However, I think a true minimally invasive surgery has as less damage as possible to the soft structures around. And I think the anterior hip, still does that. It's definitely, preferred in my mind. And one of the advantages also of doing an anterior hip is that we get to use live x-ray during surgery. It's much like having, navigation when doing the other, techniques is you can actually see exactly where the components are that you're putting in. And live X-ray or fluoroscopy is what it's called. It's a picture. So we can do the surgery with the patient laying flat, and we can see our components while we're doing it. Some of the other techniques, the patient's on their side. And it's harder to get good exposure to see exactly where your implants are or your reamers or exactly how the surgery is going. And at any time during anterior surgery, you can stop and you can take a picture and you can look and you can check yourself, which I think is very important. And it's been huge in my practice with kind of changing the course of the surgery rather than just going right on ahead and having a bad outcome. And then also for an anterior approach, I don't really give post-operative restrictions. I think with some of the posterior approaches, there's still, you can't cross your legs, you can't squat down as far. There's some restrictions, and I typically don't give those, when we do an anterior approach. I feel much more confident that the hip is going to be stable, that it's going to have less likely of a chance to dislocate, which I think is a big problem. And so here's a slide just showing some basic anatomy that, where we make the incision. That green area there is just kind of showing that you're in an internervous plane, which means you're really not violating any muscles or nerves. It's just a cleaner dissection to me to get access to the hip. Here's just a kind of a cartoon picture showing that we're kind of just pulling the muscles out of the way and we're getting direct access to the hip. All right. And here's a picture of the fluoroscopy that we use, and we can actually see exactly where we're reaming. Now that's a reamer that we use to put into the acetabulum for the cut portion. It shows our retractors and exposure, and we're actually see exactly where we're going to ream, so we know exactly where our components are going to go. And here's a picture of a total hip in place and appropriate alignment and position that we're able to confirm immediately, not with just a post-operative X-ray. Gives us instantaneous feedback and lets us know we're doing a good job throughout the case, so when we leave, we feel very comfortable. Now, computer navigation, Ken had touched on this with knees. I think this is much more innovative, and it has been huge in total hips. And this has really allowed the posterior approach to be much better, in my opinion. When you use this, you can put your components exactly where you need to be. You know exactly where they are, which is important for stability. And when he was talking about putting a total knee in, you want the components to be in appropriate position for wear patterns and for the duration of the implant. For a total hip, since it's a round joint, it's not so much as how you put them in for a wear standpoint. It has to do with dislocation, I think, is one of the biggest problems. And so, putting these in appropriate position is crucial when you're doing a hip. And if you're not able to look at it directly with fluoroscopy to know that your angles are in a very good position, I think it's appropriate and very important to use computer navigation from a posterior approach. And the nice thing is here, at Lakeland, we have both options. We're able to do any approach, access to computer navigation, which is very important, because you can't always do an anterior approach on some people. Some patients it's just very difficult. And so I think having an option to go with a different approach is very important. Having navigation to do that is huge when it comes to patient safety and satisfaction afterwards. So computer navigation, it can be used with all approaches in the hip and the knee. Some guys use it even when they do an anterior approach. Mostly I think it's for the posterior approach. And like we just talked about, why is it so important to have the components in appropriate position? And it's, like I said, not necessarily for wear patterns like in the knee when we're talking about the hip, but it's for stability. And that's the biggest thing when we talk about total hip surgery. So this is why it's important. So if this happens, this is a bad day. Somebody presents to the ER and they've dislocated their hip, and now it's got to be put back into position. They're going to have some precautions afterwards, and they may require a revision surgery. And this is just one complication that can happen from total hips. I think it's probably the second or third most common. Infection is one of the biggest causes. And then there's other, complications from total hip surgery that we get, and it's similar to total knee, like, blood clots and things like that, which through the standardization process, we've kind of eliminated a lot of that. But this certainly is my my biggest concern when I do a total hip is not having that happen afterwards. Once again, here's a list of some of the complications, and second on that list right there is dislocation. So one of the biggest reasons of why people return to the hospital and get admitted and have to have revisions, and that's something that we're able to decrease with the anterior hip approach and also with computer navigation using the other approaches. And that's it. So.